Great.
So now we have Dr. Salisbury-Afshar. She's a colleague here at UW, currently one of our faculty in addiction medicine, as well as the residency director in preventative medicine. So kind of brings both a lot of public health and preventative medicine eyes to the addiction work. She has a long background with many accomplishments, but we're glad to have her here, and I'll leave it at that.
Great, thank you. And are you seeing the right screen?
Yes.
Okay, so I'm gonna try to be pretty quick and focus mostly on kind of where we ended, which is mostly about, I mean, it's care coordination, and it just takes a ton of time. And like, I wish I had a magic wand, and it's sort of what Allison referred to, but every jail is different. And there's a lot we can't anticipate when it comes to incarceration, including how long someone will be there. And so the name of the game is like anticipatory planning in my mind. And I think like I'm going to start at the end. So that's really what it's about. It's a lot of phone calls, it's a lot of releases, and it's a lot of anticipatory planning for like, we think this, but if not, then this, and if not that, then this. So that's the conclusion. But I do always try to start my talks just with a brief land acknowledgement. I live and work in Madison. This is the Ho-Chunk Nation. I am here as a guest. In 1832, the Ho-Chunk were forced to cede this territory, and I respect the inherent sovereignty of the Ho-Chunk Nation and the 11 other First Nations of Wisconsin. You know, I think before we talk in more depth about planning for incarceration, the reality is that we often don't know if we don't ask about legal involvement. And so sometimes, you know, there's a million reasons why this conversation can feel really stigmatizing, why people may be afraid to offer this up. And so, you know, I know we all work in many different settings, but I do think that it's really important to pause and think about the way we ask about legal involvement, and then what we do with that information. I feel pretty strongly that we should always ask. However, we should only ask if we're actually going to use it in a clinically meaningful way. So meaning if I'm going to ask you about your legal involvement, all I'm going to do is drop it in a GIPRA or write it in my chart, that act alone is probably only adding stigma and no actual value to the patient. So really important to think about how we ask, and when we ask, to explain why we're asking. And so, you know, really providing a rationale. So when I ask patients about this, like, hey, we ask everybody at intake about legal involvement, the reason I ask is because I just need to understand how I might need to work with you to adjust your treatment plan, or if you need any documentation from us. We don't release this information anywhere. And being really clear, because a lot of times I'll even meet people, especially in the hospital, and if they're on probation or parole, and they like, you can see them kind of like bristle up, like, who are you talking to? Why are you asking me this? So like leading with, this doesn't go anywhere. I'm just asking it to make sure we get you everything you need. And so I would, again, sort of encourage everybody to think about how you ask this. Then, you know, sometimes if you ask people, depending on how you frame the question, you may get sort of, I mean, an accurate answer, but only part of the answer. And so typically when I ask about legal involvement, I'll ask 3 separate questions. Do you have any outstanding charges? Are you involved in drug court? And are you on parole or probation? And so I'll just briefly high level go through these, and then kind of what the different outcomes are that can happen from each of these. So if somebody has outstanding charges, you always want to ask what county. I know many of us in Wisconsin work with patients from multiple counties. That can be helpful in understanding. Sometimes I'll be like, hey, do you know what's going to happen? Sometimes people are like, yeah, I'm going to get off. I'm not worried about it. Sometimes people are like, oh, definitely mandatory time for this one. This is my 3rd OWI. And sometimes people are not sure. Just knowing that is helpful, because especially if we're starting meds, I can be already anticipatory planning, like, okay, jail, do you know how long? Again, thinking about which county would it be in? Or if it's a maybe, I'll start talking to people at the onset about, like, do we need to do any planning? If you think it's a maybe, like, we should be aware, you know, if we're starting this med today, will you be able to continue it? And if not, to Allison's point, maybe we move to a long-acting injectable much faster. I often will document court dates just so we have a sense of, like, when are we going to have more information. And then if somebody's anticipating jail time, asking about, again, thinking about MOUD and what they're hoping to start. Probation and parole, I'll usually just ask, and again, document for what length of time, what county is their probation or parole in, does their PO know that they've, they're using substances or returned to use, do they know that they're here asking about meds? And here I'll usually just be like, do you want any documentation? Do you want documentation that you came to the visit? Do you want documentation that I'm prescribing this med? And I'll just type up a letter. I usually just straight up give the letter to the patient instead of faxing it out and getting a release. So that way they have it if they want it and need it, but it doesn't kind of open that door for us to start getting phone calls from a PO, et cetera. I will also often ask people two other questions. Are you concerned at all about revocation? Revocation means that you break the terms of your probation or parole and you can go back to being incarcerated. And again, that's when we would open this conversation about, does the jail or the prison allow MOUD? And if not, what would we need to plan for that? The second question I usually ask is are you getting drug screened by your PO? What's your relationship like? Especially if people are coming into us with a lot of drug use. And they are getting drug tested by their PO, I kind of always file it away in my mind, it feels like this could be a case where jail could potentially be an option if they're getting drug screened and there's lots of ongoing drug use. So just understanding that relationship is helpful. Again, I'm never reaching out to anyone else, but it's just sort of making me think about, we offer everyone long-acting injectables, but in these cases, we might be offering them sooner and just making sure people are kind of thinking ahead, if this were to happen. And then finally, treatment court. So when people are in drug court, they are typically, assigned to a drug court in a specific county. They move through court phases. And especially the earlier phases, if people are repeatedly not doing well, it is possible that they can be reincarcerated. So if they are not, if they don't, quote, graduate from drug court, typically they go back through traditional court proceedings, often with a high risk, although not always a guarantee of going back to jail. So again, just kind of understanding how they're doing in that drug court process. Are they anticipating sort of leaving the treatment court program or, any possible return to incarceration? So again, each of these are sort of conversations I would have. Sometimes it's no, no, no. And in that case, it's a really fast conversation. But in the case they answer yes to any of these, there's more information we can gather. So again, if you're going to ask questions about legal involvement, we have to be prepared to follow it up with supports. So writing letters to say, yep, they're coming. Yes, I made this diagnosis. I started this med. If there's any pushback from a PO or a judge, really documenting, this is the medical diagnosis. This is my medical recommendation. Again, assuming the patient wants that, and then being able and willing to share those resources with the patient and or with the court or the PO if that's what the patient agrees to and signs a release for. So in any of those cases, the patient says, yes, I think I'm going to have to do some time. This is sort of my high-level thought process, and then I'll go through a specific case that is a real case, but it's a couple years old at this point. So first, if somebody says, yep, I think I'm going to have to go back to jail or go to jail, the first things I'm thinking about are which jail and what meds are you on and what meds do we think you'll need and want to continue while you're incarcerated. Now, I will say, especially many of you are PCPs, if you're a PCP, I would be thinking about the entirety of their med list, especially if you're in a more rural area, because we've seen challenges with people getting all kinds of meds and then getting really big bills. So I would be looking at their full med list and their, and then call, again, with patient permission, and I've done this different ways. Often if somebody is not actively incarcerated and you call the jail, even with a signed release, they're like, we don't know who you're talking about. We're not going to answer questions about someone we don't know, but you can ask for formulary. So for example, I could call and say, hey, I have a patient who's anticipating being incarcerated. I usually ask to talk to the nurse. Can you tell me if buprenorphine and fluoxetine, for example, are on your formulary? And if someone comes in already on those, what documentation do you need for them to be able to continue? So that's sort of the first question. The second question, and this one applies more to our more rural county jails, is does the person need to bring their own meds? And the answer there is highly variable and it's going to depend on the jail. There are jails where if you bring your own meds, as long as they're sealed and from the pharmacy, they will dispense them. And it ends up being way, way cheaper for the patient if they're able to bring their own meds. And so just understanding what's allowable. The third thing, if the patient is comfortable, they can sign a release of information so that you can communicate with the jail medical team while they're incarcerated. In this one, and this was the question that I was going to ask for the case that Maggie presented, is did you guys get an ROI for the jail? Because if yes, that would be a time where I would start calling the jail and saying, hey, look, their Sublocade injection is going to be tapering down. We would be happy to give them another injection if you can get them here, which they won't unless they're on Cuba or something, at least not in my experience. Or could you guys sort of start giving sublingual bupe because you know that their dose is going to be too low, and unless you have Sublocade, which again, most jails locally don't, but you could ask. So just letting them know, like, hey, we have a release. We're allowed to talk to you. Their 3 or 4 weeks are up. We anticipate they're not going to be feeling well. Can you give sublingual? Can you give Sublocade? Can you get them here? But if you have that signed release, you can coordinate on their behalf. And then the fourth, and this gets, I think this one has been really important for us in several circumstances, but saying like, okay, I'm going to use a fake name. Okay, Joe, we know you're going to be incarcerated likely for 6 to 9 months. While you're incarcerated, we're probably not going to be able to talk to you directly. We have a release for the jail, but like the jail doesn't usually call us proactively to care coordinate. So is there anybody you want us to talk to while you're incarcerated if we need to coordinate care? So so it could be that Joe's 3 months of meds that he went in with are out. And so we're going to coordinate with his sister to call in a script and have the sister come pick it up, for example, and take it back to the jail so the costs are lower. It could be that his sister is going to call us and say, hey, good news, Joe's getting out next week. How can I schedule his follow-up appointment with you guys? So having those releases both for the jail and for a trusted friend or family member, especially the person that they're going to try to stay in touch with while they're incarcerated, can be really helpful. And it just gives us a little bit more wiggle room for continuity of care. Many folks are probably already aware of this, but just want to remind that medications for opioid use disorder and the diagnosis of opioid use disorder is sort of a covered, there are protections in the Americans with Disabilities Act. And according to the Department of Justice, not allowing someone to continue prescribed MOUD while incarcerated is a violation of the ADA. So we really want to, if patients are telling us, or if a jail is telling us, like blanket statement, we never allow people to continue bupe, even with a med list, even with, proof of prior prescription, we can, and I would say should, let our patients know that they do have the right to file a complaint with the Department of Justice as a civil rights violation. I will say I've talked to the DOJ Civil Rights Department. This should really come from the patient, not from a clinician. It includes PHI. The only caveat is if, I've had patients who struggle with literacy or maybe struggle, don't have easy access to internet. Like we've worked with them to fill it out, but for themselves, right? So for their own name and like going through it with them when they've needed assistance. But the guidance is this really needs to be coming from the person because it is their civil right that's being violated. Final takeaways. First, standardize the ways you ask about legal involvement. We want to ask about different types of legal involvement, ideally using non-stigmatizing terms, asking permission to collect it, and very clearly, if we're gonna ask, we need to be ready to hold up our end of the bargain to do something useful with that information. If we know somebody's anticipating jail time, we want to be thinking about whether or not they can continue meds in jail. If not, we want to be thinking about long-acting injectables, especially as it relates to buprenorphine. We need to be thinking about the ROIs that should be signed in advance so we can coordinate both with the jail and ideally with a trusted family member. And then making sure we're starting to think about re-entry and like how to make sure people know we want to see them back at the point of re-entry.